From the 33rd Annual Meeting and Exposition of the American Society of Hematology, held December 6th through 10th, 1991 in Denver, this is a live recording of Tape 19, the Wasserman Lecture.
I just found out 5 minutes ago that I was introducing my friend of some 21 years, Dr. Uri Seligsohn, to this audience, and it's indeed my pleasure to do so. Uri Seligsohn is a graduate of the Hebrew University School of Medicine. He had his internal medicine training and hematology training at Sheba Medical Center in Tel Aviv. He came with his beautiful young wife and 2 children, I think at that time, to Los Angeles in 1970 as a postdoctoral fellow in my laboratory, where he distinguished himself, amongst other things, in completely reorganizing my laboratory, making it much more efficient than it was before his arrival. He's worked on fibrinogen metabolism, on factor 7 and its metabolism, on protein C. He has a wonderful ability to look at a situation and see, oh, here's what I can do to learn something. And he found himself in Israel with populations of patients that he could study for the genetic transmission of hemorrhagic diseases. And working with Dr. Barry Collar and Peter Newman, he's made some very interesting observations on Glanzmann's thrombocythemia. It is a very real personal pleasure for me to introduce to you Dr. Uri Seligsohn.
Dr. Margeris, Dr. Rappaport, ladies and gentlemen, I want to thank you and the Society for the great honor extended to me by your invitation to present this year's Wasserman Lecture. In this presentation on hereditary bleeding disorders, I shall start with a brief introduction on the mechanisms of blood coagulation and then focus on recent developments in hemophilia A, factor 11 deficiency, and Glanzmann thrombasthenia. For many years, physicians and scientists have known that the blood coagulation systems are delicately balanced. This balance has been illustrated by my friend Dan Kedar, who is an Israeli surrealist painter. Can we have the first slide, please? Our life is like walking on a tightrope between the constant threats of both bleeding and thrombosis. Next slide, please. Here is an oversimplified schematic representation of the coagulation systems. It will set the stage for our main topics. It is a result of several decades of research initially carried out by physicians and physiologists at the bedside and clinical coagulation laboratories. Later, in the 60s and 70s, the biochemists brought in protein chemistry and enzyme kinetics. And even more recently, the molecular biologists have introduced cloning of the genes controlling most coagulation factors and thereby reliable means of carrier detection and prenatal diagnosis of some of the severe coagulation disorders became available, as well as the production of factor 8 and factor 9 concentrates produced by genetic engineering. One direct consequence of this multifaceted approach to blood coagulation is our current understanding of the recognition of the great heterogeneity of the hereditary bleeding disorders, which were once believed to be quite uniform. Classically, 3 overlapping mechanisms that can lead to thrombosis or hemostasis are set in motion when the vessel wall is injured. The most immediate mechanism of blood vessel wall interaction, of platelet vessel wall interaction on your right is now quite well understood. Significant components of this interaction located in the subendothelium on the surface of platelets and in the plasma have been identified and well characterized. Glanzmann thrombasthenia, in which there is a lack or malfunctioning of the platelet receptor glycoprotein 2B and 3A complex, has served as a disease model to study the mechanisms involved in the aggregation of platelets at the sites of vessel wall injury. I shall return to it later. The so-called extrinsic coagulation system in the middle is triggered when the factor 7 present in the blood interacts with tissue factor localized deep in the vessel wall or in the surrounding tissues. This complex, tissue factor, factor 7, generates small amounts of factor 10A. From the studies of Yale-Nemerson and others, we know that factor 10A can activate factor 7 bound to tissue factor, thereby greatly amplifying the initiation of the extrinsic coagulation system. However, several years ago, an efficient natural inhibitor which shuts off this pathway was discovered and recently was given the official name TFPI, tissue factor pathway inhibitor. How then can this roadblock be removed? In 1977, Östrud and Rappaport showed that tissue factor, factor 7, can also activate factor 9. And in the presence of factor 8A, more factor 10A can be generated. This pathway, which is not affected by TFPI, is extremely important, as can be inferred from the severe bleeding tendency of hemophilia A and hemophilia B patients. The contact phase of the so-called intrinsic coagulation system on your left is triggered by the activation of factor 12 due to the interaction with the subendothelium. Theoretically, this system can be a source of additional factor 10A. However, the importance of this initiation pathway has been seriously questioned, since patients, as you all know, who have severe deficiencies of factor 12, high molecular weight kininogen, and prekallikrein do not present with a bleeding tendency. In contrast, however, factor 11, which also belongs to the contact system, does seem important, since its deficiency can be manifested by severe post-trauma bleeding, which I'll show later. So, is the contact phase of this system essential or isn't it? One way to explain the variable manifestations of factor 11 deficiency versus the deficiencies of the other contact factors is that there might be a mechanism that bypasses factor 12 and directly activates factor 11. Such a bypass was reported a few months ago from the laboratories of Fujikawa and Bros. Both groups showed that factor 11 can be activated by thrombin or auto-activated by factor 11A in the presence of negatively charged surfaces, thereby bypassing factor 12. What this could mean is that once small amounts of thrombin are generated through the extrinsic coagulation system, thrombin can then activate factor 11, it activates also factor 8, and then factor 5, and this activation of factor 11 then can generate additional amounts of factor 9A and 10A. Let us now concentrate on factor 8 deficiency or hemophilia A. Can we have the next slide, please? About 25 years ago, when I trained in hematology, this man shown on this bad old slide was the first hemophilia A patient whom I met. He was confined to a wheelchair due to joint contractures the consequences of untreated hematrosis, and also because of hemiplegia, probably related to intracerebral hemorrhage, which he had experienced during infancy. At that time, the Judy pool cryoprecipitate was just introduced. The history of hemophilia is highlighted by attempts to prevent this terrible disease and alleviate its suffering it inflicts on patients and their families. I will review only the attempts to prevent the disease, but first present an historical example. Next slide, please. Here is a text from the Talmud, which cites the first instance of genetic counseling for hemophilia that took place in the 2nd century AD. Rabbi Judah counseled a woman who had 2 sons that died after circumcision not to circumcise her 3rd son. Another rabbi ruled that circumcision should also be avoided if 3 sisters of a woman in question had a son who died of bleeding. Clearly, the sex-linked mode of inheritance was understood by these rabbis. In the late 50s, fetal sex determination in amniotic fluid became possible, and thus women who were obligatory carriers of hemophilia A could be provided with the means to prevent the disease. Next slide, please. At that time, most carriers chose to terminate all male pregnancies in spite of the 50% chances of having a normal boy. In the 70s, it was finally realized that factor VIII and von Willebrand factor are different molecules that circulate in the blood as a complex, but can be assayed separately. Since factor VIII and von Willebrand factor are concordantly synthesized and controlled by different genes, one on the X chromosome and one on chromosome 12, the expected ratio between factor VIII and von Willebrand factor in carriers was about 0.5. However, due to different degrees of X chromosome inactivation and variability in assays, this ratio had a substantial range. Nevertheless, by repeated testing and discriminant analysis, potential carriers of hemophilia A could be offered a method to determine their carriership status, although only in probabilistic terms. For instance, a woman would be told, your chances of being a carrier are 10%, but this statement is only 90 to 95% accurate. Next slide, please. In 1979 and the beginning of the 80s, several centers, first in the United Kingdom and then in France and then in the United States, developed the technique of fetal blood sampling. Blood was initially drawn through a fetoscope, as can be seen on this slide. In defined carriers who chose to undergo the procedure, the practice has been first to determine the sex of the fetus by amniocentesis, then to draw a blood sample at the 18 to 21 week of gestation, and measure factor VIII activity and antigen. A breakthrough occurred in 1984 when the gene for factor VIII and the protein were characterized. Next slide. It turned out that the gene is a very big gene with 186 kilobase and 26 exons. The protein has several domains, and there are different forms present in the plasma. And here down is the activated form, the result of several cleavages by thrombin. Soon after, several restriction fragment length polymorphisms in the factor VIII gene were found either inside the gene or outside the gene, or closely linked to it. These RFLPs have nothing to do with the mutations causing hemophilia, but enable the tracking of the mutant genes indirectly in families affected by hemophilia A. They have become extremely helpful for carrier detection and prenatal diagnosis. Let me illustrate this by an example. Next slide, please. In this family, there are several patients with severe hemophilia A, and obviously the mothers are obligatory carriers. We track the mutant gene in this family by the intragenic BCL1 RFLP. By using PCR, a 142 base pair DNA segment which contains the polymorphic site is amplified and then subjected to cleavage by BCL1. In the hemophiliac here, you can see that the X chromosome contains the polymorphic site since the 142 segment was split into 99 and 43 segments. The mother, who is an obligatory carrier, contains, of course, the same allele and the normal allele that was not cleaved. Both sisters had the same pattern as the mother and were therefore carriers. One of the sisters recently came to us for counseling during the 6th week of gestation. She underwent chorionic villi sampling at the 10th week of gestation, and the DNA of the fetus was tested by a probe which identifies the Y chromosome and also tested for the BCL1 polymorphism. The results disclosed, unfortunately, that she had a male fetus carrying the polymorphism, and thus an abortion was carried out. We must realize that prenatal diagnosis using RFLPs can only be performed if the carrier is heterozygous for the polymorphic site, and thus the heterozygosity rate in females of a given population determines the usefulness of the RFLP. Next slide. The current status of the most useful polymorphisms and hypervariable repeats is summarized in this slide. Next slide, please. With the BCL1 that identifies a polymorphic site in intron 18, 44% of women are informative heterozygotes. If we also add the XBA polymorphism in intron 22, this number is increased to about 70%. Adding the TAC1 polymorphism brings this number to almost 100%. However, it should be noted that the TAC1 detects an extragenic polymorphism, and therefore a 5% recombination rate is possible. Recently, Laloz and from the Tottenham group in the United Kingdom characterized an intragenic variable cytosine adenine repeat in intron 13 and obtained 91% heterozygosity. Next slide. There are inherent limitations in using these techniques. First, as I already mentioned, it is an indirect method. There is a need for samples from several family members, including one hemophiliacs, and as already mentioned, up to 5% recombination rate is present when the only informative marker is extragenic. And in sporadic families, about 30% of all families, the diagnosis is possible by exclusion only. Given these limitations, we hematologists have been looking for methods to directly detect the mutations in hemophilic patients under our care and then track them in family members. However, this seemed like a dream until recently for two main reasons. Haldane in 1935 had already predicted that numerous new mutations of hemophilia A must be introduced into the population at large, given the constant prevalence of the disease and the low reproduction rate of hemophiliacs. Secondly, the enormous gene shown before seemed like an Everest to climb. Next slide, please. Initially, the attempts were quite frustrating. Using Southern analysis, only 5% of the mutations were discovered, and these were deletions or insertions. When the target of the search have been hypermutable cgDNA regions or regions coding for essential factor VIII functional sites, even then the yield was quite small, as you can see on the right column. More recently, with the advent of very sophisticated techniques and aiming at the whole gene, almost all of the mutations are detectable. This ingenious research, performed mainly in the United States by the groups of Gitcher and Kazasian, and in the United Kingdom by Gianelli, Cooper, and Taddenham, has already characterized more than 150 mutations responsible for hemophilia A. However, even if these methods will be widely applied within the coming years, at the bedside, matters will be different, since our convictions and suggestions and our patients' decisions frequently diverge. This divergence is illustrated in the next slide. Here you can see the results of a study that was carried out in the Netherlands in a large population of potential carriers of hemophilia A, and you can see that 42% of relatives of hemophilia A, severe hemophilia A patients, were opposed to any kind of prenatal diagnostic procedure. And next slide. Back in 1979, next slide please. Back in 1979, when we had the World Federation of Hemophilia Congress in Tel Aviv, one of the hemophiliacs got up and said, "We hemophiliacs are not children of a lesser God who gave you the right to propose the killing of hemophilic fetuses." And one obligatory carrier once told me, "My rabbi heard your advice and said, 'No way, don't listen to him.' So I carried on my pregnancy and had a third hemophilic son." Thus, ladies and gentlemen, molecular genetics has provided us with very powerful means to prevent hemophilia in well-studied families. Molecular genetics has also provided us with safe recombinant factor VIII and factor IX products, which will be used more widely once their prohibitive price has come down. Still unresolved problems remain. Primary prevention is not applicable to 1/3 of the cases since there are new mutations. The correlation between the mutations and the phenotypic expression is not always uniform, and the consent of carriers to prenatal diagnostic procedures is limited. We all hope that gene therapy for the hemophilias will be introduced within the next years and definitely before the turn of the century. Let me now move to the second part of my talk and focus on recent findings in factor XI deficiency. Next slide. Factor XI is a glycoprotein with a molecular weight of 160,000. Its plasma concentration is about 4 microgram per ml with a T-half of 50 hours. It consists of 2 identical subunits linked by a disulfide bond. Upon activation by factor XIIa, thrombin, or 11A, as I already mentioned, each subunit is converted into a serine protease, which then, in turn, can activate factor IX. It is synthesized in the liver, and the gene for factor XI is located on chromosome 4q35 and consists of 15 exons and 14 introns. Next slide. Factor XI deficiency is a mild to moderate bleeding tendency. Bleeding is usually related to trauma and is capricious. Some patients bleed, some patients don't bleed, some patients bleed on one occasion and not on another occasion, and the inheritance is autosomal recessive. Heterozygotes rarely manifest bleeding, although there are some reports that heterozygotes do bleed. It is very rare in most populations, and as I'll show you later, it is quite frequent in Ashkenazi Jews. Similar decreases of both antigen and activity have been demonstrated, and there is an effective treatment by fresh frozen plasma or by a recently developed factor XI concentrate, about which you'll hear later during this meeting. About 15 years ago, I reviewed the mode of presentation in 36 patients with severe factor XI deficiency. Next slide, please. In most patients, the diagnosis was made following some kind of a trauma. Here you see 14 out of 19 patients, or during screening tests. Next slide, please. Looking at the pedigrees, I was struck by the fact that all patients were Ashkenazi Jews originating from Eastern and Central Europe, and by the occurrence in 3 families shown here of what seemed to be an autosomal dominant and not an autosomal recessive mode of inheritance. My interpretation was that this could be a consequence of mating between homozygotes and heterozygotes. However, this would imply that the gene frequency of factor XI deficiency among Ashkenazi Jews must be extremely high in order to account for the chance clustering of the mutant gene in these non-consanguineous families. Next slide. Therefore, we carried out 2 surveys of factor XI deficiency and found severe factor XI deficiency in 6 out of 1,141 Ashkenazi Jews. In other words, 1 out of every 190 Ashkenazi Jews has a severe deficiency, and up to 14% of the Ashkenazi Jews carry the mutant genes. To understand this enormously high gene frequency in such a relatively small population, I must make a digression and present some historical facts. Next slide, please. In this slide of the Middle East, you can see that between 722 to 886 before Christ, Jews have been expelled from Israel by the Assyrians and Babylonians and resettled in Babylon, which at present is Iraq. Next slide. The Babylonian Jews are considered to be the original gene pool of all Jews. Some stayed in the Middle East and are now called the so-called Oriental Jews. Some migrated through Israel, Egypt, and North Africa into Spain, and these are the Sephardic Jews. And the third segment, the Ashkenazi Jews, returned to Israel and constructed the Second Temple, and in 70 AD they were taken in captivity by the Romans and spread throughout Central and Eastern Europe. When the descendants of these people, next slide please, came back to Israel during the last 80 years, and as you all know this process is still going on, 3 striking genetic features were made, or observations were made. First, there were substantial differences in the external features of the people who came from different countries. And I'll give you a few examples. Next slide. Here is an Oriental Jew coming from Iraq. Next slide. Next slide. Here is a Yemenite boy. Next slide. Next slide. 2 Indian Jewish sisters. Next slide. A Libyan Jewish woman. Next slide. And an Ashkenazi woman holding her son. They happen to be my daughter and my grandson. Next slide, please. Yet when one looks at a series of 40 genetic markers and then calculates the distances in different populations, you can see how far, for instance, the Polish Jews are from the Poles, and how far distant are the German Jews from the Germans, and how more closer the Iraqi Jews are to the Russian Jews and the Polish Jews. The third interesting genetic feature was a high frequency of hereditary disorders in the various communities. For instance, Tay-Sachs and Gaucher's disease among Ashkenazi Jews, factor VII deficiency associated with the Doomin-Johnson syndrome in Iranian Jews, familiar Mediterranean fever and amyloidosis among the Sephardic Jews. These genetic aberrations probably stem from founder effects, drift, and high rate of consanguinity in those communities which were isolated for about 25 centuries. Returning to factor XI, about 2 years ago, Ray Asakai, working in Earl Davies' laboratory in Seattle, discovered 3 point mutations of the factor XI gene in 6 Ashkenazi Jews, and these can be seen in the next slide. The type 1 mutation is a splice junction mutation in intron N, The type 2 mutation is a nonsense mutation in exon 5, and the type 3 mutation is a missense mutation in exon 9. For all three mutations, Asakai developed a diagnostic PCR, which we decided to use with the following aims: to assess the relative frequency of these mutations among our patients, to correlate the various genotypes to factor 11 levels, and to study the relationship between bleeding manifestations and genotypes. Before I present the results, let me show you an example of one diagnostic PCR. Next slide, please. For the detection of the type 3 mutation, a 245 base pair segment is amplified, and this segment contains the site of the type 3 mutation. Using the MBO1 restriction enzyme in a control, one can see that this is split up into two segments of 125 and 120 size. In the homozygous patient, there is no cleavage by the MBO1 restriction enzyme, and in a heterozygote, obligatory heterozygote, you can see the normal allele and the abnormal allele. Next slide, please. We studied 43 unrelated patients with severe factor 11 deficiency. As you can see, 10 were homozygotes for the type 2 mutation, 20 were double heterozygotes for the type 2 and 3 mutations, 10 were homozygotes for the type 3 mutation, and 3 were compound heterozygotes who have one allele with an as yet unidentified mutation. Thus, it seems that the type 2 and the type 3 mutations are the predominant mutations in the Ashkenazi Jewish population with equal frequencies. We then looked at the levels of factor 11 and APTT in the different genotypes. Next slide, please. As you can see, in the upper row, the type 2 homozygotes had the lowest factor 11 level of 1.2% mean. Here are the standard deviations. The type 2-3 compound heterozygotes had 3.3%, and the type 3 homozygotes had the highest level, 9.7. And the differences between these groups are highly significant. When you look at the APTTs, there is also a highly significant difference between the three genotypes. Looking at the heterozygotes, the type 2 heterozygotes have 52%, and the type 3 heterozygotes had 67% of factor 11 level, and these differences are significant. Careful analysis of the patient histories revealed that injury-related bleeding episodes were significantly more frequent in patients who were type 2 homozygotes when compared to the type 3 homozygotes. We also looked at the proportion of surgical procedures that were complicated by bleeding in patients with the various genotypes before they were known to have factor 11 deficiency. Next slide, please. Dental procedures on the right column, you see, were frequently accompanied by bleeding in all genotypes. Similarly, surgical procedures at sites with a known local fibrinolysis were also complicated by bleeding quite frequently. When we compared the proportion of bleeding complications in this group of the tonsillectomy, urological surgery, nasal surgery, to all other surgical procedures, like appendectomy, orthopedic surgery, hysterectomy, the difference is 12 out of 16 versus 8 out of 38 was highly significant, and there is a mistake here. This should be, the P should be less than 0.01. We recently challenged our conclusion that local fibrinolysis indeed is an important factor and tested whether an antifibrinolytic agent can prevent bleeding following dental extractions in patients with severe factor 11 deficiency without plasma replacement. Next slide. 19 patients with different genotypes who had previously bled following dental extractions before the diagnosis was known were given tranexamic acid 1 gram 4 times a day from 12 hours before dental surgery until 7 days thereafter, without any plasma replacement. Except for oozing in one patient that occurred on the 3rd day, there was really no complication whatsoever. Therefore, I believe, ladies and gentlemen, that the genotype and local fibrinolysis are important determinants as to whether or not a patient with severe factor XI deficiency will bleed following trauma. However, there may be additional causes for bleeding which we shall have to identify in the future. Another question which needs to be addressed is whether patients who are heterozygotes for any one of the mutations described and others that will be described are at risk of bleeding. Let me now turn to the third and last part of my talk, Lanzmann thrombasthenia. Platelets under normal circumstances circulate along the vessel walls but are repelled from the endothelial cells by various compounds like prostacyclin and endothelial-derived relaxing factor. Next slide. However, once a crack occurs between the endothelial cells, platelets immediately adhere to the vessel wall by means of surface glycoproteins which recognize constituents in the subendothelium. For example, the glycoprotein 1b recognizes from Willebrand factor that it is embedded in the subendothelium. The complex glycoprotein 1a, 2a collagen and the glycoprotein 2b, 3a recognizes the von Willebrand factor. And there are, as you all know, additional ligands. Following adhesion, platelet aggregation takes place. Next slide. And we know a great deal about its mechanism. The bridges between the platelets, connecting the platelets, consist of glycoprotein 2b3a on the platelet membranes and fibrinogen in between. Next slide. This is what the glycoprotein 2b3a complex looks like. There is, here is the glycoprotein 3a with a large extracellular part, and this is the glycoprotein 2b that has 2 chains. The genes for both glycoprotein 2b and 3a have been characterized and are closely together on chromosome 17. Next slide. Under resting conditions, the glycoprotein 2b, 3a complex cannot bind to fibrinogen unless fibrinogen is immobilized on surfaces. However, once platelets become activated, the glycoprotein 2b and 3a complex recognizes several domains on the fibrinogen, a dodecapeptide on the gamma chain of the fibrinogen, and 2 RGD domains on the alpha chain. Since platelet aggregation is crucial for the formation of an arterial thrombus, for instance in the coronary vessels, means to interfere with the interaction between glycoprotein 2b3a complex and fibrinogen, for instance monoclonal antibodies, peptides, could be of great potential therapeutic value. Lanzmann thrombasthenia has been an excellent model for studying this interaction, since we know from the work of Nurden and Kahn in 1974 and others that glycoprotein 2b3a complex is missing or defective in such patients. Next slide. Thrombasthenia is a rare disease and is quite heterogeneous. Broadly speaking, there is a type 1 thrombasthenia with less than 5% of the glycoprotein 2b3a complex, and there is no platelet fibrinogen. In the type 2 patients, more than 10% glycoprotein 2b3a is present, and there is some fibrinogen. In the variants, there is a dysfunctional glycoprotein 2b3a complex. And even when one looks at the type 1 thrombasthenic, there is quite a heterogeneity, but clinically speaking, they are quite uniform. Next slide, please. The type 1 Glanzmann thrombasthenia is a moderate to severe mucocutaneous bleeding tendency. The inheritance is autosomal recessive. There is a prolonged bleeding time. There is absent clot retraction and isolated platelets on blood smears. Next slide. There's no aggregation in response to all agonists except for ristocetin. There's normal adhesion to subendothelium, normal secretion following thrombin stimulation, no fibrinogen binding, and absent or abnormal glycoprotein 2B3A complex, and as I already mentioned, there is quite an heterogeneity. Next slide. About 17 years ago, I realized that the type 1 Glanzmann thrombasthenia is another relatively frequent disease in Israel. 37 patients from 21 families were of Iraqi Jewish origin, and 12 patients from 5 families were of Arab origin. Clinically, Iraqi Jewish patients and Arab patients were indistinguishable. Arab families were also described by Awidi from Jordan, and 2 additional thrombasthenia clusters were reported from southern India and among the Gypsies in France. In 1983, Barry Kohler from Stony Brook spent a sabbatical in Israel, and it was then decided to devise methods for carrier detection and prenatal diagnosis of thrombasthenia and to characterize the biochemical defects in Arab and Iraqi Jewish patients. Next slide. Our first aim was partly accomplished in 1986 using Barry's labeled monoclonal antibody 10E5, which recognizes the glycoprotein 2B3A complex in a platelet binding assay. We were able to distinguish quite well between patients, obligatory carriers, and controls. While the controls bound about 40,000 antibody molecules per platelet, and thrombasthenic patients hardly bound any, the obligatory carriers, except for a few outliers, bound a significantly reduced number of antibody molecules. We therefore began to use this binding assay for carrier detection and for prenatal diagnosis by fetal blood sampling. Next slide. We then examined the nature of the glycoprotein 2B and glycoprotein 3A in Arab versus Iraqi Jewish patients. We found by immunoblotting, as you can see here, that the glycoprotein 3A, here is the control. In the Arab patients, there was a reduced amount of glycoprotein 3A, whereas in the Iraqi Jewish patients, there was none whatsoever. Thus, it seemed that the Iraqi Jewish patients have a different disease than the Arab patients. In collaboration with Russell and Quatermass from the Massachusetts General Hospital, further studies using a large number of restriction enzymes and cDNA probes failed to show major deletions in the genes for the glycoprotein 2B and 3A in both populations. Consequently, we decided to look for a more subtle defect, for which purpose we invited Peter Newman from the Blood Center of southeastern Wisconsin to come over to Israel. Next slide. Peter's approach was to prepare platelet-rich plasma and extract the RNA out of the PRP and prepare cDNA by reverse transcription and then amplify segments of the glycoprotein 2B and glycoprotein 3A and sequence. Next slide, please. In all Iraqi Jewish patients that were studied, a uniform 11 base pair deletion was found that caused a stop downstream. This can be well illustrated in the next slide. In the translation, right before the glycoprotein 3A is anchored into the membrane. And there is also, in this, because of this stop, the loop, an SS, a big SS loop, cannot be closed. No wonder, therefore, that the Iraqi Jewish patients have a total lack of glycoprotein 3A. Please note that during this meeting, we'll hear 3 more papers describing point mutations and an insertion in the glycoprotein 3A gene in other thrombasthenic patients. Next slide. The Arab mutation was found in the glycoprotein 2B gene in 3 out of 5 family studies. It is a 13 base pair deletion that encompasses a part of the intron 3 and extends into the exon 4. Now this causes an alternative splicing to the next AG. As a result, there is a lack of 6 amino acids, one of which is cysteine, and probably this causes a defective folding of the glycoprotein 2B, and this can be illustrated in the next slide. Here is the glycoprotein 2B, and the small deletion was found close to the N-terminal. Recently, there has been a report on a large deletion in the glycoprotein 2B by the group of Pons from Philadelphia. Next slide. Peter Newman then designed oligonucleotides specific for the normal sequence and for the abnormal sequence. And using allele-specific hybridization, we were able to pick up the normals and differentiate them from the Arabs. However, faced with very large pedigrees, we looked for a more simple technique, and Chava Peretz in my laboratory devised such a method. Small segments of DNA containing the mutation of both Arab patients and Iraqi Jewish patients were amplified by PCR and checked for differences in the size on electrophoresis. Next slide. Here you see a normal control. The PCR amplifies a segment with the size of 128, and here you see an Arab thrombasthenic who has the PCR amplifies a segment which is only 115, 13 base pair deleted, and the differences can be easily picked up. And here are several heterozygotes. Note that on the left lanes, these are samples taken from urine epithelial cells, and in fact we need only 50 ml of a urine sample to do the tests. This simplified method, next slide please, has enabled us to study 3 huge Arab families, like the one shown here, and to determine the genotypes for future counseling. Next slide. A similar approach was used to detect the Iraqi Jewish thrombasthenics. Here on the right-hand side, close to the marker, you can see that in the normal control there is an 80 base pair segment that is amplified by the PCR, and on the lane 3 you see the thrombasthenic that has only 69 base pairs, and here is the a heterozygote that cannot be seen so well. A few weeks ago we had the first chorionic villi sampling in a mother who had a thrombasthenic child. And as you can see on the left-hand side, unfortunately, the fetus was affected by thrombasthenia, and next to it is another chorionic villi sample from a normal fetus. One of the outcomes of these studies is shown in the next slide. Look at Barry Kohler holding one of the children that was born after prenatal diagnostic procedures. And definitely everybody is quite happy here. Next slide. What should be done in the future? We have to detect more mutations, since we know that in our population there are more defects that are different. This will enable us, as well as other studies from different groups, to understand better the structure-functional relationship of the glycoprotein 2,3A complex. There is an interesting question that we may explore the possibility that heterozygosity for thrombasthenia confers protection against arterial thrombosis. And we hope to provide better counseling and prevent the occurrence of the disease. Finally, next slide, I want to acknowledge the dedicated work of my associates in Israel, Ariela Tzivlin, Chava Peretz, Eti Zwang, and Ruja Eichel. Next slide, please. I want also to thank the participants of the various collaborative studies, Barry Kohler, Peter Newman, Glansman Trombastenia, Ray Asakai, Earl Davey, in the studies on factor 11 deficiency, and earlier studies that were done in collaboration with John Griffin, Saito, and Bauma, and my Israeli collaborators, Shlomo Berliner, Benny Brenner, Uri Martinovich, David Voron, Muhammad Yunus, and Aida Inbal. And finally, special thanks to my teacher and friend who introduced me to science more than 2 decades ago, Dr. Sam Rappaport. Thank you very much.
On behalf of the Educational Committee of the American Society of Hematology, we want to thank you for a marvelous lecture and to present you with this plaque of our appreciation.
Thank you very much.
This concludes the 1991 Ham Wasserman Lecture.
This concludes this session from the American Society of Hematology.